Good evening. My name is Dr. Markella Mickelson, and I am CEO and co-founder of Molmart. My interest and the interest of Molmart is to provide actionable solutions for the prevention of inherited genetic disease. And much of what I will present to you today stems from our earlier work in prenatal diagnosis and the evolution of that work. I will presume that many of you here today are offering PGS to your customers as part of your IVF business, with a view of eliminating aneuploid embryos and increasing the probability of implantation. And perhaps you're also offering PGD in cases of family history of genetic disease. I will refer to these terms from now on with their new names of PGT-A and PGT-M for aneuploidian monogenic disease. So today, I want to give you a fresh perspective on how we can truly prevent genetic disease. I also want to show you how what we do now in terms of genetic screening has much room for improvement, and how we can take the process of genetic screening one step back in the life of the embryo from prenatal to preconception, and how you can help your patients benefit from this technology and help them bring to the world healthy children, which is, I'm sure, what they want. So I will present to you two scenarios. These are real live case studies from our company. The first scenario you will probably recognize because it represents the status quo. The second scenario is a fresh perspective of looking at family planning, and I hope it will provide you with food for thought and some points of discussion later on today. We have been conducting prenatal screening for over 15 years, and the scenario I'm about to describe to you is something that we have encountered time and time again. I am just using a family as an example, and this scenario may also be familiar to you. So let's consider this family scenario. We have a young couple, and their firstborn child is born with congenital deafness. The condition is suspected to be genetic, but it is undiagnosed. The couple now want to have a second child. They want to have a second pregnancy. They come to us because they want to know what to do. What are the next steps? And how should the couple plan and manage a second pregnancy? And I hope this scenario is familiar to many of you who have had a couple come to them with this problem. So they have a child with a suspected but undiagnosed genetic condition, and they want to know what to do next. So what are the options for the couple in this scenario? And as you can see, they are actually quite limited. So the first and possibly the best option is to enter what we call a diagnostic odyssey for the first sibling. And I call it an odyssey. This is a very apt name because it takes, on average, 7 tests. It takes, on average, to see 4 physicians and wait for 4.4 years before a person can receive a diagnosis. Approximately 50% of patients with a rare disease receive a misdiagnosis. So this is definitely not the quick option for the family. The second option is to put the second pregnancy on hold. And many couples opt not to have another child because they don't want to run the risk of being placed in the same situation again with a second child with the same problem. Or they could be misadvised and go through routine prenatal diagnosis after conceiving naturally, or they may go through IVF and have PGT-A. But as you all know here, neither of the above is able to identify the genetic syndrome from the first sibling. So routine prenatal diagnosis is very much concentrated on Down syndrome and other aneuploidies, as is PGT-A. So they will be unable to identify what is wrong with the first child. So if this couple then conceive naturally, they are now in a position of what I call a game of Russian roulette. They have a 1 in 4 risk of having a child with the same condition as the first child. So I have two questions for you at this point. First of all, is this scenario familiar to you? Have you seen this before in your practice? And secondly, is there a better way to plan this? Is there a better way to do it? And of course, the answer is yes. And I will show you a better way to do this in the next few slides. I just want to spend a few minutes going through how genetic disease is passed on from generation to generation for those people in the audience that perhaps may not be so familiar with this subject. So what we call Mendelian disease or inherited disease is passed on from generation to generation in three different ways. The first one's called dominant, and in dominant genetic disease, only one copy of a faulty gene suffices to cause disease. The second copy is normal. And carriers of dominant disease generally, typically show symptoms of the disease. Most familial forms of cancer are of the dominant inheritance type. The second one, which is actually the one that is most challenging to us geneticists, is recessive, where both copies of the same gene need to be faulty in order to cause disease. Carriers themselves are healthy because they only carry one faulty copy of the gene and they have no symptoms of the disease. There are many diseases that form this pattern of inheritance. For example, cystic fibrosis, beta and alpha thalassemia, sickle cell, and over 5,000 other genetic diseases. And as I say, this is the one that proves to be most challenging to us for many reasons. And I will focus largely on the recessive form of inheritance. And finally, we have X-linked, where the faulty gene is on the X chromosome. And for this reason, males are much more frequently affected than females because they only have one copy of the X chromosome. And an example of this is Duchenne muscular dystrophy. So focusing on recessive, I want to show you a typical autosomal recessive inheritance pattern. So let's assume this is our couple, and both prospective mother and father are carriers of the same pathogenic mutation in the same gene. This is unbeknown to them because they're both healthy. They're showing no symptoms of the disease. So characteristically, carriers will not know that they're carriers of a genetic disease. So if we look at this scenario, they have a 1 in 2 risk, a 50% risk of having children who are also carriers. And most likely they will not know that they're carriers, so they will run the same risk as their parents. And most importantly, they have a 25% risk, 1 in 4 risk of having children who are affected by that disease. The risk remains the same for every pregnancy, whether the couple has an affected child or not. What does that mean? In the example I showed you earlier, where the family already had a child that was affected by the genetic disease, it doesn't mean that because they've had the affected child, the other 3 will be normal. The risk resets itself at the outset of every pregnancy. So they're always, for every new pregnancy, they're always running that 1 in 4 risk. So why is carrier status a problem? And a lot of the time, I think we focus on the affected person. You know, our focus and our diagnostic endeavors are focused on the affected person. But actually, we should shift that focus from the affected person to the carrier. And this is really a new way of looking at things. Why is carrier status a problem? The short answer is that carriers are not always aware of their carrier status. So let's take recessive disease as an example. Carriers of recessive disease are asymptomatic. They don't show any symptoms of the disease, and therefore they don't know that they have a 25% risk of having sick children. Like the example I showed you earlier, the couple was unaware of the disease risk that they had. and they didn't know about it until they had their first child. Similarly, carriers of dominant disease may not be aware of their carrier status, because sometimes dominant disease can have much milder symptoms. It may be masked, it might have limited penetrance, or it may skip a generation. And many cancer genes behave this way. So let's take the BRCA family, for example, BRCA1 and BRCA2. So carrier of BRCA1 and BRCA2 has an increased risk of developing breast or ovarian cancer, but it's not a guaranteed risk. They will not necessarily develop breast or ovarian cancer. However, if they pass this gene on to their children, which is at a risk of 50%, their children might then go on to develop ovarian or breast cancer. In female carriers of X-linked conditions, they may not know themselves that they are carriers. Usually they don't, because the normal X chromosome masks the faulty gene. And they will only find out when 50% of their male children will be affected. A statistic that might be interesting to everyone here is that on average, we are all carriers of 12 pathogenic mutations. Now, happily for us, it is not a problem, because most of these are recessive. So as I said, carriers are healthy. They don't show any symptoms of the disease. But it is a risk if both ourselves and our partner carries the same genetic mutation. So given what I've just said, most carriers don't know they're carriers until it's too late. And what do I mean by too late? Well, if we think back to the scenario I've just described to you, with a family with a child with congenital deafness, too late means they have a child that shows symptoms of a genetic disease. And that genetic disease could vary from extremely severely life-limiting to fatal. But let's think of a different question. What if it was possible for a couple to know in advance if they were both carriers of a life-limiting genetic disease? And if that was the case, if they knew they were carriers of a life-limiting rare genetic disease, how would they plan their pregnancy? Would they leave the health of their child to chance, knowing full well that there is a 1 in 4 probability that their child will be affected? So going back to that question, is there a way that we can tell carriers that they are carriers of a genetic disease, bearing in mind there are over 5,000 genetic diseases to screen for? So Malmart has been working for the last 7 years, pretty much, on developing a service that will help couples before they conceive to know if they're carriers of a genetic disease or not. The service is based on whole exome sequencing. So 10 years ago, really, this wouldn't have been possible. But with the technology that we have available today, and with the relative speed and cost of whole exome sequencing, we can actually look at someone's exome relatively quickly. So we have developed a service with a bespoke bioinformatics algorithm that was co-developed with the University of Manchester Bioinformatics School. We have developed a single test which will screen for over 5,000 known genetic disorders all in one go. And these 5,000 genetic disorders translate into over 10,000 genes, which in themselves translate into over 150,000 genetic variants. So let's assume that we can now turn the clock back for the couple that I described earlier. So let's say they had the possibility of taking this test, which is trading under the name Shawmart. Let's assume they had the possibility of taking this test before they plan their first pregnancy. How would the options now look for them? And again, this was a real test in our lab. So when we screened the two parents, we found that they were both carriers of a pathogenic disease-causing mutation in the gene MY07A. They were carriers of two different variants. So the mum had was a carrier of a different variant from the father. And this gene encodes for an unconventional myosin. What this means for them is that they have a 1 in 4 risk of having an affected child. And the child would be a compound heterozygote. That means they would inherit two different variants for MY07A. And this is consistent with Usher syndrome type 1B for non-syndromic congenital deafness. If the child inherits both pathogenic variants from the parents, there is near to 100% probability that the child will show the phenotype of the disease. And this is exactly what happened in the scenario that I showed you earlier. So what are the options for the couple now? You remember the earlier example, their options were rather limited. What are their options now? Well, let's look at this. First of all, time is on their side. So they would have time to sit down with a clinical geneticist and receive genetic counseling to understand the impact of the result. One of the options open to them is to go down the route of IVF, and I'm sure this is very, very relevant to many of you here. So they can undergo IVF with PGT-M to select and implant healthy embryos only. Another option is to conceive naturally and do early prenatal screening for the variant. But this time we know what we're screening for. And another option is to use donor sperm or egg or go down the route of surrogacy. And for a proportion of couples, they just want to know their risk and then leave everything to chance. So how is this result useful for the couple? Well, most importantly, the couple knows before conceiving that they are at risk of having a child with a genetic disease. This means that they have the time, the luxury of time, to think about their options and to make an informed decision. They now can have early prenatal testing for the specific mutation because we know what that mutation is. So we can plan specifically for that mutation. And the final option is to enable the couple to select the implantation of healthy only embryos through IVF. And this particular option is the one that almost near eliminates the need to terminate a pregnancy. So in terms of having to make some difficult and challenging decisions down the line, this is possibly the one that eliminates this. So the journey for the patient, and this is taken from our website, the journey for a patient that wishes to undergo Shawmart is firstly to have a one-to-one genetic consultation with a clinical geneticist. And this will allow the couple to understand what the impact of the results is going to be. They then undergo the test, which is very simple. It's a saliva-based test. It's a spit in the tube, which they can then send back to either their clinic, to their doctor, or to us. We analyze the DNA. We provide a comprehensive clinical report of their risk, having screened for over 5,000 genetic diseases. We then follow the whole process with a very important step, a one-to-one consultation session with a clinical geneticist, so the couple understand the relevance of their results and they can go through the options that are open to them. So who's Shawmart for? I'm sure you get many couples in your clinics that want genetic screening, they want PGTA because they want that extra reassurance that their child is going to be healthy. So these couples will be reassured by this extra step, this extra level of confidence, knowing that they have been screened for all these diseases and they will not be running the risk of passing them on to their children, or if they do, they can take precautions. Couples such as the one I showed you earlier with a family history of undiagnosed suspected genetic disease, either in the close family or a close relative. So SureMod is for them. And the final group is consanguineous couples, and they run a significantly higher risk compared to non-consanguineous couples, because obviously if one person in the couple is a carrier of a particular recessive disease, it is much more likely that their partner is carrier of the same mutation because they come from the same family unit. Now, at this stage, you may have patients that are saying, well, these diseases are very rare, so, I'm just going to take the chance because it's not going to happen to me. So I want to give you some numbers, some statistics to help you understand how relevant and how frequent genetic disease actually is. I know the word pandemic has been used loosely a lot in the last year and a half, but there are areas in the world that have almost an endemic of genetic disease, a very, very high incidence of genetic disease. So worldwide, there are approximately 300 million people living with a rare genetic disease. So when we apply the term rare collectively, it isn't actually that rare at all. Rare genetic disease affects more people than AIDS and cancer combined. In fact, I read one statistic that said if people with a rare disease were all put in the same country, it would be the 5th most populous country in the world. We now have more than 5,000 recognized single gene disorders according to WHO, and the number is increasing all the time because of our better knowledge of genetics. And very importantly, 40% of pediatric hospitalizations are due to genetic disorder. So it really is a problem down the line when the child is born. In terms of incidence, 1 in 100 babies is born with a genetic disease. And genetic disease is not cheap. In the UK, it costs the NHS up to £1.7 million annually to look after a child with a genetic disease. It is not cheap for the healthcare system. It is not cheap for the family. Some kids will need 24/7 care. It is also emotionally and mentally very, very demanding. So genetic disease is a real problem in our society. I want to finish with 4 very important points. So I hope I've shown you how we envision the future of prenatal and preconception diagnosis. I'm hoping that it's a fresh take on how we do prenatal or preconception diagnosis. I know there's a number of companies out there that offer genetic tests on things like lifestyle factors or some interesting genetic traits. And that is good to know. But I can reassure you that out of the 150,000 genetic variants that we look at, we only focus and we only report on the genetic variants that are known to be associated with disease. Their pathogenic implication has been proven in silico to be deleterious, and it leads to actionable results. They're well documented variants in the literature that are firmly associated with life-limiting or fatal genetic disease. So we don't report on any gimmicky genetic traits. This is not what you will get from us. Another point I want to make, and I showed you this in the patient journey, the pre-test and the post test genetic counselling is very, very important, and we don't want to take shortcuts here. This is where the patient understands what the result means for them and what they can do about it. The collaboration between us and the physician, us meaning both the geneticist and the clinical geneticist, is very, very important. In the example I gave you, there are over 100 forms of congenital deafness, and it's only by working together with you and a clinical geneticist that we can home in to find out exactly what the genetic mutation is and what we can do about it. So by working closely, we maximize the health benefits for the patients. And finally, a general remark that exome sequencing is becoming a generic test for a lot of genetic diseases. We're moving away from single gene tests or even panels, and we're looking at exome sequencing as a tool, not only for diagnosis, but also for extending our existing gene lists and for reanalyzing data that has already been produced. So I hope that what I have said gives you a fresh perspective on how we can prevent and predict genetic disease. This is very much a new field, and possibly many of your patients and possibly many healthcare professionals out there are not aware that this technology exists and what it is possible to do with it. So if you have patients that want to know a little bit more and want to eliminate even more risks from their forthcoming pregnancy, they may want to know that this service exists and the opportunities it offers to them. So if you were interested in what I had to present today and you'd like to know more about it, do visit our website on molmart.co.uk. Do feel free to contact either myself, M. Mikkelsen, or our commercial director, Mr. Khan, on the 2 email addresses I've given here, or through our contact us page. And I know I recognize some names on the agenda today. We are already connected on LinkedIn. We will be delighted if more of you would like to connect with myself or the company on LinkedIn. So this is all I have to say today. Thank you very much.